workforce. Let's just change, here we go. And also there is an opportunity to change. There's some background noise there, Kirsten, can you? Anyway, there's an opportunity here to move, so fielding the health reforms and the move into localities, we are also on a continuum of moving away from a model of just a GP and just a nurse and just 15-minute appointments, and I'll talk about that further, and a breadth of workforce for a genuine whānau-centred, community-focused health and social care determinants workforce, breadth of scope. So that's on the workforce side, and clearly from a patient point of view, the whole population health need has grown. People are living longer. There's a higher incidence of disease for Māori that hasn't been served, and we know that. And you know, some of those opportunities sit in the new model and the new world that we're moving into inside the next 12 months, which is pretty exciting. So moving on and keeping an eye on the time. What I'd like to do now is just remind us what is lean, and I'm going to go through the basics of lean, but also link it to the healthcare home model, because the other thing I notice that sometimes healthcare homes is seen as these things over here plus lean. I see lean and everything about the healthcare home as one thing. I don't see that you can separate it out, but I'll try and explain why I think that. Hopefully you'll all know some of the history here. Lean or Kaizen came out of the Second World War and the Toyota production system. Some of the background was that Japan had no resources, no materials, no money. They were on their knees, and they could no longer manufacture, for example, cars by stockpiling them and investing heavily and then waiting for a customer. So just-in-time production was one of the drivers. And also a need to deliver a really quality product. So that was some of the background, and I'll come back to why does that matter in health as we move through lean. The other really important thing about lean is that it's continuous improvement, and that sounds blindingly obvious. And there are lots of continuous improvement methodologies. And sometimes people go, well, why is lean, you know, why lean? What I think is important about lean is that it's ground up, everybody, everywhere. So it really means that instead of having, say, special Six Sigma consultants come into your business, do lots of, you know, diagrams and then tell you what to do, it is using the same methodology. Actually, the two have the same root, but in every single individual who works there. So it's about embedding lean understanding and culture and thinking for every staff member. And it helps drive an improvement capability, so an ability to actually deliver on improvement, as well as a change in culture. And there's, you know, there's so much here. I could talk about just those things for the next 20 minutes, but I won't. And you'll know and you'll remember, no doubt, that it's there to eliminate unevenness or waste or overburden. And we'll talk about all these things as we go through. Overburden, particularly in health. I think of a GP sitting with an inbox late at night and coming across a 10-page discharge, or results sitting in an inbox that we don't have enough staff to look at. Not only is that work that is not being done, but it also leaves staff feeling very worried about the risk that they're not covering. And if they're under that sort of set of circumstances for a really long time, it's incredibly stressful. So it's not just making things efficient or leaning things, which I think is not a great phrase, actually. It's about genuinely taking away the waste in our lives to release us for the time for what health is really about, which is actually creativity and people connection. Okay, so I'm hoping that all resonates. And so what I wanted to talk about was this concept of waste. You know, why is that useful, and how can you use it in general practice? And one of the things that general practice is full of is an opportunity for standardization. And of course, in Cornerstone and in our quality world, we have plenty of processes and protocols, either usually in a book somewhere or on a directory, but that doesn't mean that everybody knows how things work. Sometimes I have noticed in general practice, there will be people who have been there for years who have all the knowledge in their heads. And when they leave, a lot of other people go, I don't know how that works. A lot of stuff isn't written down. There is quite a lot of variation. So it's about setting standards and everybody knowing what they are, and using all sorts of tools to do that, not just to have a piece of paper sitting somewhere. And it is also about, so standards is like a really key part. And it is also about identifying problems and fixing them. So general practice quite often identifies problems all day long. People are walking around going, that didn't work very well, or that's broken, or why can't we do that, or that's stuck again, or that thing. But nobody actually does anything about it. Everybody's too busy. So how do you actually build in time to identify and improve? And I'll talk about that too. And I also want to talk about some of the metrics here, so this is a people, performance, and process triangle, and learning how to measure and then build improvement and then measure again. So we'll touch on that, and that's all related to waste. And of course, the flip side of waste is processes or problems. So we'll look at, okay, once you do identify a problem, how, what can you do about that? Prioritizing them, etc. Okay, so eliminating waste, increasing value. I think it's helpful to think of, let's think about value first, and think about what is value. And it's a really core part of Lean. And Lean says that really the ideal process is start, deliver the value, and finish. Once you get that in your head, you learn to see things differently. So value, if value is one side of a coin, the other side of that coin is waste, right? And really often what you're trying to do is see waste, get rid of it in order to increase value. And that sounds very theoretical, but for example, in general practice, our model of care is based very much these days, and it is changing, on firstly, a patient letting us know that they need us. So it's a pull effect. If they have an appointment with us, they come and sit in our waiting room and wait for an appointment. Then they have the appointment and then they leave, and maybe they get a prescription afterwards. So the appointment, you could argue, and the prescription are the value point, and the perfect process would be not sit in the waiting room. Come at exactly the right time, have the value, leave. So you could say, why do we have waiting rooms? And that very question is a good Lean question. Okay, why do we? And one of the things we at a practical level in our practice did, because we had a waiting room, quite a big one, and we ran out of space like most people do, we, especially during COVID, there was a real opportunity to reduce waiting very significantly to nothing. And then as we came back to, okay, do we let everybody in? Do some people sit in the car? Do some people get a virtual consult? Do some people come and sit here? It's quite good that we don't have lots of people all in one room. And can we move to a almost no waiting at all process? We've not got there, but we've improved. And we've released space in our reception area to have 2 healthcare assistant little offices. So we've actually created 2 little offices, and our HCAs do a lot of pre-work. So sitting right next to the waiting room works well for them. So that was kind of 2 little Lean things came together. So what I'm talking about is learning to see, or putting your Lean lens on, and teaching everybody else how to see too. So there is an element of teaching Lean in practice. And I think we've got all PHO today, for you to go to teach Lean so that other people can teach Lean. It's a kind of role modeling, paying forward process, actually. And once you start using Lean language or demonstrating Lean tools, then you're teaching somebody, say a practice manager or a lead nurse or a lead admin or an HCA in practice, to do that too. And so what you start doing is empowering small teams to do work together, and we'll talk through that a bit more. The other thing I wanted to say, and this kind of relates to Lean everywhere, every day, is that what Lean also recognizes is that change does not happen in the boardroom. You don't sit in the boardroom and go, why is repeat prescriptions not working? One of my sort of pet hates is you don't send out a survey monkey going, why is repeat prescriptions not working? Because you're not going to find out. The real way to find out is to map it and or actually follow it. Go and talk to the people who do the repeat prescription. Stand right there, look at what the GP is doing, then go and, you know, Gemba walking. So that's a bit of it, kind of starting what's lean all about. And as I said, I wanted to link lean to the healthcare home model itself and remind us where healthcare home came from, right? And it came from general practice, going to go and have a look at some lean tools in Boeing, in Seattle, and thinking, wow, that's really interesting, and learning some stuff about delivering a quality service or product consistently and involving your workforce in that process. And they came away with this model of care. And one of the things when I went to my healthcare home boot camp a long time ago now, one of the things that really resonated for me was that the phrase, if you are only offering one kind of healthcare repeatedly in a cookie cutter style, you're not a healthcare home. In other words, if all you do is wait for a patient to manage to get through to you and then to sit in your waiting room and then give them a 15-minute appointment with a GP and with a nurse doing certain standard things, and then they go home, that's not healthcare home. So what is, and kind of what I wanted to paint a picture of, was this a business and practice that is mature enough and developed enough to offer multiple things, to offer the right thing to the right person at the right time, to have a breadth of service delivery, and in health that's workforce breadth, and to understand what the patient needs and be able to deliver that. That sounds quite challenging, actually. All of a sudden you're like, oh God, how do we get there? And healthcare home certainly helps that, right? So it's from one single service cookie cutter offering to variable appointments with different appointment types, possibly across multiple platforms. Instead of just being reactive to what walks in the door, is both, it's reactive and proactive. Instead of never having enough capacity to meet demand, and this feels permanent, it does have capacity. And also, how do you know? How do you know? Oh yeah, I've got the right people. Instead of just being reliant on quite a narrow workforce, it's got this real breadth. I mean, I can digress on almost every single one of these points, but what I would say about breadth, just looking at workforce and at Tikipunga, we have really got a significant breadth, partly in response to COVID and lack of GPs. We use a pharmacist twice a week to look at complex medicines reconciliations. We have HCAs doing really high scope work to support nurses. We've got health coaches, we've got a social worker, and one has to become more standardized in pathway, documentation, referral agreements. Otherwise, you'd never know who's working on what, would you? Right? It becomes so. As you broaden your workforce, you can't just work it out as you're going along, or just do what you used to do before, because it'll become too confusing, actually, and it'll just be an expensive general practice. And so also from little teams who've known each other for years and years and years and years, who sort of work it out in the corridor, to bigger teams with multiple disciplines, with a different range of hours, with a different range of modalities, with different possible technical systems, multiple people coming in and out. That's a very different kind of business to run, and run well. And so, you know, I guess being more mature around processes and standardization and problem solving is actually an important part of making that work. And we're starting to talk about possibly a localities picture. I digress again. And from kind of low creativity to high creativity, and I'll come back to the point I made earlier, and I think it's worth saying this. Sometimes in general practice, I hear people say, hang on a minute, lean is a manufacturing process. Healthcare is not manufacturing. Fair, okay. Lean is used very heavily in healthcare, and one of the reasons is because let's standardize and reduce waste in all the boring stuff, how to do a prescription, how to book an appointment, how to schedule something, how to make a clinical triage call, make that nice and clean, so that you release heaps of time for the good stuff, for the juicy stuff, for GPs to have proper amounts of time, for social workers to have hours to, you know, proactively work with nurses to look at certain comorbidities. That's why. And so lean really actually is a platform for all the value in healthcare. And so really this slide is kind of in response to, because quite often it sounds like we're talking about process. And sometimes in lean, we will say process, not people. That doesn't mean we don't value people. It's exactly the opposite. We value people so very, very much that we want to get rid of the waste. I mean, why would you waste people's time, for goodness sake? And also let's empower everybody to do that. It's not a special management job. It's not like Mel knows and nobody else knows. Everybody knows. So we're coming up to our first breakout, and I'm just going to check where we're, bang on time. I said round about 10:30. So I'm just going to give you a little explanation as to what I'm looking for, and then Kirsten is magically going to put us in breakout groups for 5 minutes. And what I wanted us to think about is start the sort of, session thinking about value, or who is this value for? And I wanted to think about who's the customer and what does good look like. So the customer from a lean point of view it's useful to think about in a three segment view, either the business or workforce or the patient. I sometimes think business or system. So health system, is this working for the health system? But certainly it is valid to say, is it working for the business? Financially, economically, capacity-wise, practically, and so on. And of course, patient as well as workforce. So your breakout for the next 5 minutes, what I'd like you to think about is what is good? What does good look like for a patient? Or what does good look like for workforce? And I've given you some examples here. So for example, for a patient, good might be, I feel valued and my needs are met. Or for a person who works in your organization, good might be, I feel confident that I can do my job, right? So this is kind of, before we come into problem space, I'm deliberately putting us into visioning space, really. And I'm going to let Kirsten give you 5 minutes to think, what does good look like for each of the 3 segments, please. Kia ora, everyone. Hello again. We were just remarking amongst ourselves that it's difficult to see all the faces when I'm presenting. So I've taken it off slide view just for a brief kind of to, see everybody, and wondered if 1 or 2 wanted to volunteer to share what they thought good looks like. Anyone want to have a go?
I'll have a go, Mel.
Thanks.
We had a very, 5 minutes goes fast.
Yeah.
One of the things that we did talk about though is what would good look like for a customer would be the choice of modality and provider when we access health services, so that our time is not wasted either in a waiting room or processes that actually we have no control over, but they're offered up. So
great example. Yeah, right after my heart here. Anyone else?
Yeah, we talked about not only having your needs met, but maybe your wants met as well. And taking that a little bit further, that perhaps the practice is anticipating your wants and reaching out to you in a proactive way.
Wow, love it. Last one, anyone got anything?
Building on what Marie said, we sort of acknowledge that the healthcare model of care actually has it all in there, doesn't it? That's sort of the utopia.
Yeah, exactly. It sort of does help even make some sense of it. Okay, thank you so much. That's really great to hear where your thoughts are. And we shall go back into the body of the workshop. So that's exactly as you said, and I've got a few what does good look likes here. I can use technology to make my appointments. I can have different appointment lengths that suit my need. I can meet the right health professional. I think what's so interesting about that point about modality and health professional and choice is that in a practice where we have significant workforce challenges, and this is something I experience, it's exactly the opposite of that. We don't have appointments for weeks and weeks and weeks. There is no choice who you see an appointment for. Too bad. You might not even be able to choose male or female. Versus, I've looked at some online offerings around mental health recently, that are a completely transformed experience. There's this amazing website with lots of fantastic resources, with a range of different professionals from different cultures, with different languages, with different backgrounds, that you can choose who you want to see. You can get an appointment really quickly. It's all online. There are resources that go with your health need. Now that stuff, we're not there yet, but that is kind of what we're talking about. And I'm quite encouraged to hear, just for the little bit of feedback we've had, how far ahead you're thinking. That's amazing. You know, the healthcare home of 4 or 5 years ago is already old. Moving on. So, but exactly as we say, actually it's all in there, right? So of course, access is a critical part, and healthcare home, when it started, was all about call handling, because that is how our patients reach us at the moment, increasingly changing. And the real basics of, well, for starters, answer the phone, which is kind of basic, isn't it? But a lot of practices, when they are not a healthcare home, don't measure their calls. They do not know how many calls they're missing. And in our experience, most of them are missing about 50%. That's a lot. Mm. And if you're a practice that is missing 50% of your calls, you are probably not geared up to meet the real demand. So if you suddenly answer all your calls, you won't have appointments. So the capacity and demand thing is right there, call handling. And one of the other things that I certainly feel strongly, having at Doctors Tikiponga, I started as a healthcare home change facilitator 5 years ago. I worked with them for 3 years. I've been managing them for 2, and we still don't have this right. We've got a lot better, but it's still tough. So just answering calls, and then knowing how many of those are likely to become same-day appointments or routine appointments is the start of knowing your demand in order to have the right capacity. Again, I could have a workshop on every single one of these subjects, but we're just kind of moving on. So there's access. Then there's proactive care. Instead of waiting for people to go, oh yes, I'm falling off the cliff, I really need a GP. And again, I'm sure you all know the theory, but actually putting proactive care in place in practice is challenging. And it's particularly challenging if you haven't got unplanned demand under control, because you'll go, well, when am I supposed to have a 3-hour meeting with all my nurses looking at some data? What? And my answer to that would be, obviously, get unplanned demand under control. In other words, implement standardization, use lean processes, have the right capacity to meet demand. Okay, then, and then actually schedule it. Right, on Tuesdays, we're going to have a proactive care clinic. This is what it's going to look like. These are the people who are involved. This is how we're going to start, and build it into practice. And the third sort of pillar, as we all know, is the workforce pillar. So broadening those roles. And that is, of course, a journey that goes on for years and years and years, but also very significantly a journey that localities will accelerate. And not only will we have broader roles in general practice, but we may be working with other colleagues either right next door or possibly inside. So the HIP and health coach model, sitting in our practice, working in a multidisciplinary way to support our patients on all their needs. And of course, future-proofing general practice. And this is a massive subject in itself, around the professionalism of it for nurses and for GPs and for many other kinds of health professionals. You know, again, there's a lot of opportunity, let's put it that way, a lot of work to do as well. Okay, so I wanted to kind of go into using the lean tools, and I wanted to get fairly practical about it. I am actually quite a practical person. So I'm just going to go through some stuff. I'm going to start with a real old nugget, clinical triage. Actually, I'm just going to stop sharing just for a second. I'll be quite keen. Can you put your hands up to tell me if you're using well, you're all PHO people, but have you implemented or do you have practices who are using clinical triage systems? Quite a few. Yeah, great. Okay. So you'll know that plenty. You'll know it well. So you'll know why. And from a lean point of view, if you have, let's say you've got 100 phone calls coming in every day, just to give us some kind of metrics on this, and 50% of those are same-day requests. In the old days, you would have had a certain amount of reserved appointments for your same-day requests. You would have given them to the first 30 people who arrive. The process would be who decides? Well, the patient and an administrator, that's who decides. And when those same-day appointments ran out, that's it, they've run out. And actually what would happen to the remaining same-day demand is it would end up with nurses who would triage it and possibly try and see it and then go, oh no, you need a GP. And so you're double handling lots of stuff. It's not right place, right time by any means. You are not using your nurses to the best of their scope. And also you end up with that sort of double booked template look, or lots of nurses hovering in corridors. I don't know if that's a familiar sign to you. You get nurses waiting for a GP for something. Oh, can I just nip it? Can I just... why do clinical triage? So also, and practices will have experienced this, during COVID, demand levels generally went up and then down. So they fluctuated very significantly. And same-day demand or urgent and repeat prescriptions is inside the urgent channel. In our practice went up by 150% the day before level 4. Wow. And so what do you do with that? Do you just don't do it? Just cut it off? Or do you try to meet it? And the answer is in the word triage, isn't it? That when in health we have more demand than we have resources for, what do? We triage it. That's what we do. So great. A clinician calls a patient back because we know that a proportion of those can be resolved on the phone. That's in the interest of the clinician and the patient. And it also gives us the opportunity to deliver a right place, right time outcome. Oh, yes, I need to see you. Oh, no, my nurse needs to see you. Hang on a minute, go and get your blood pressure first. Oh, the pharmacist can sort that out. Hang on, I can send you to a CVAC center. Post-COVID, it's become way more complicated. There's lots of answers. It's not just come and see a GP. See a GP online, see somebody else online, see a counselor, come and see my hip, go see an agent, blah, blah, blah. So somebody has to make that decision. And to make it work, so let's say you've implemented it, your practices are doing clinical triage, the next step then is maturity, making that process work well. And that takes time. It's not a process that just miraculously works well. It's actually quite complicated. And the reason why it's complicated is that we need to understand incoming demand versus outcome. And that would drive what our templates look like, how many GPs we've got, how many nurses we've got, how many different specialists we've got, how many, smears do we need, how many vaccinators. So looking at your service delivery by demand level and being able to recruit to that means that you have capacity to meet demand. I'm hoping some of this is making sense. I'm not going to go much more on why, but what I also wanted to talk about was when you look at data, this is data from where were those urgent calls, requests for urgent appointments from, for a practice in Northland. And you can see how, from a patient point of view, not having to come into the practice if you didn't need to is really helpful. And if you overlay a rural picture on that, for example, I live rurally, and if I had to go into the practice to get a prescription to then go to a pharmacist that isn't in my town, you can see how it might take me all morning for that, as opposed to a phone call. And some of what I'm also trying to say is that when you're working and maturing clinical triage, from a patient's point of view, the best perspective is I phone my practice and I get through straight away. And then if I need an urgent appointment, I get a phone call back really within the next hour. So quickly, not later today. And either that's resolved for me on the phone, or if I need an appointment, I get one. So that means that we've got the right capacity for phone answering. We've got the right capacity in our templates for calling back. And we have the right resources, enough locked off days, for example, to give appointments when we need them, to achieve what I've just said, the perfect process. And from a, for example, practice manager point of view, or a, PHO facilitator, if you're working with a practice, you would need to look at the sort of data I've got in front of us now. So I absolutely monthly look at how many phone calls versus how many clinical triage calls versus what's the resolution. And then I look at GP templates. As a practice that's been doing clinical triage for 5 years, what we have found is that we've driven up an expectation that you will get a call back. And in the last year, we have an enrolled population at Tikipunga of 8.5. We have about 40 or 50 callbacks every day. That's 2 to 3 hours of GP time. It's a lot. But you could imagine, what if they'd all come into practice? How would you do that then? Knowing the numbers, building those into, for example, we have regular monthly meetings where we look at those numbers, we look at resolution rates. There's another little thing I want to say, which Jess and I were musing on the other day. The healthcare home model has this metric of resolution rate. In other words, how many phone calls did not need somebody to come back in. You'd finished and served, you'd provided, you know, whatever it is that they were needing on the phone. I think it's really important to know that that is an indicator, not a target. We're not targeting people to resolve it on the phone. Either they need it or they don't, right? And from a medical point of view, there's so many factors that can change resolution rate. Who's the GP? What's the modality? How old is the person? You know, what ethnicity are they? Where do they live? How many comorbidities do they have? There's so much that can change resolution rate. So I kind of quite passionate about, we're not driving people to not bring people in. What we're looking for is a right place, right time, right delivery answer, and to serve patient choice. And I think what I've just talked about is kind of almost old-fashioned already, because ideally in the future world, we wouldn't be making a phone call, or we could choose our channel. Some people might want to make a phone call. Some people might find it easier to get online, and we can already help people book through Manage My Health, but it could be much more seamless, couldn't it? You know, so I think that's some of the future. Okay, so we've talked a bit about clinical triage, and I wanted to carry on staying practical and talk about some more actually using lean in practice. I wanted to use the favorite lean word, standardization. So once we start talking about standardization in our practice, we use the term, what's the standard? And we've been, you know, thinking like a lean practice for such a long time. I have many different members of our workforce who will say to us or to each other, hey, what's the standard here? Do we know the standard? Hang on, I don't think we know this. It usually happens when maybe a problem has been identified. A patient came in and something happened and it caused distress and somebody was interrupted. Why did that happen? What's our standard for when that happens? And so we socialize the idea of standardization, and we socialize the idea that we follow a standard, and when we find that there's something not right about the standard, we don't just change it by ourselves. We come together as a group and have a discussion about that. So one of the things I've found is that sometimes there are certain people who are really enthusiastic, which is fantastic, yay, and they see something wrong and they just fix it. And nobody else knew. Then you're like, no, don't do that. So the point about a standard is that we all know what it is. And if somebody sees something wrong, that's awesome. Come and bring it back to the time to discuss it. And I'll talk about that as a group. Because also the other thing is that sometimes we only see a process problem from our point of view. We don't know what happened before and we don't know what happened after. So we might change it and actually have an unintended consequence. Or admin usually would go, hang on a minute, did you think about us here? Normally, no. So teaching standardization means agreeing how we do things, all knowing it, all being able to go, that didn't work, I have an idea about it. And then together going, okay, then we'll change that process. I'll give you a really basic example, actually. Last year during COVID in our general practice, there came a time where we needed to make a decision about opening our doors and being able to manage patients who were sitting in a car, patients who were going to come to a COVID corridor in a different door, patients who were going to come in, and not too many. And that was quite resource intensive. You know, do you have a person standing at the door all of the time? That's not great use of your resource. And quite quickly, the admin team actually came to a suggestion. We have a slidey window that we would shut the door completely and say, go to the slidey window. And an admin person would sit there and open the window and then essentially direct. That's a great idea. It then became the standard, and it was admin who came up with it because they could multitask while standing at the window, whereas standing at the door meant that, you know, they really were kind of almost in a confrontational position, kind of going, you can't come in. So it's a simple example, but it shows also how you can empower people to come up with those ideas themselves and problem solve and then implement new processes. Standardization, or the removal of waste, of course, in business terms, how much money do we waste waiting for things? How much time do we waste of nurses standing in corridors waiting to get prescriptions signed? Anybody who's not on e-prescribing yet, I actually went into a practice the other day, clearly they're not, and there was a pharmacist standing in the waiting room with a pile of paper, maybe they were controlled drugs, waiting. Waiting. So another thing that's also worth talking about is interrupting. General practice is a reactive place. The whole model at the moment is a reactive model. And actually people who work in general practice are quite keen to fix things. Right, I'll sort it out. And it drives a reactive business culture. I found when I first started working in general practice that people would interrupt with anything. And they'd interrupt everything, you know, they'd even wait for you outside the toilet. And soon I was, without being rude, like, hang on a minute, can it wait? Yes, it can wait. Can it wait till Tuesday's huddle? Yes. Okay, then bring it to Tuesday's huddle. So teaching people to not just interrupt each other all of the time, giving them a time to have that conversation. Obviously, if you don't give them that time, that's quite frustrating for them. So building in a Tuesday huddle, on Tuesdays for 30 minutes, we look at stuff that went wrong last week. We do some problem solving around that. We make some decisions and then we move on. Can it wait till Tuesday? Yes, it can wait. If you've got a Post-it note in your hand, that's fine. Put it on the board. Honoring that commitment, actually giving them the Tuesday meeting, actually listening to what's going on, actually problem solving, you know, that's also really important. But not encouraging, particularly as leaders, not a interrupting culture. And the other thing about being interrupted is it's actually deeply disrespectful. It's because if you work in a busy environment of great complexity, which is what primary care is, and you're trying to do something which has risk involved, good decision making, for example, and you're being interrupted all of the time, that's stressful. That's actually stressful. And nurses will say to me, wow, I was able to work from home for 2 hours doing recalls. That was so satisfying. I got so much done. Well, why aren't we enabling that? You know, why do we continue to ignore, oh yeah, you can squeeze that in amongst all those other things. It's actually not lean. You don't get the work done well. You don't get it done straight away. And you probably make errors and mistakes. So interrupting all the time drives rework and errors. It also drives micromanaging, which is not a great idea. So reducing rework and waste and wait time and all that sort of overburden improves staff morale and satisfaction and getting the stuff out of healthcare that we were there for, you know, having valued conversations with patients, and improves patient satisfaction because patients are getting right time, right place, and also actually meeting a much happier workforce. So, you know, I think there's a whole pile of stuff to be talked about in terms of how happy are the people you meet who are working in primary care. Are they happy? Or are they just like, because that's not great, is it? And what can we do to help them? Okay, so this is a slide, and I've just also got lean thinker Jo Henson's business there because she puts this slide up when she's teaching lean, and it's got some of those basic lean foundations. And I've pulled out their waste and process, and I have also talked about Gemba walking or going to see. And just to briefly touch on that again, particularly for this audience of PHO members, you know, if you want to walk the talk and embody lean, thinking and lean culture, go into practice and spend time with people actually doing the work. Don't just meet at PHOs and talk about it. Go and observe, put your lean lens on and look for waste or look for value, and also role model lean thinking. And I'll talk a bit more about that as we move into leadership. So we're not that far away from our second breakout. And what I wanted to talk about before we go into that is this lovely subject of waste. Now, some of you may have seen this slide before. It's the different types of waste. And I wanted to give you some examples of these before I put you into a breakout to think of further examples yourselves. So waiting, we've talked about waiting in the waiting room. Why? Waiting for a practice to answer a phone call, waiting for a prescription, over-processing. So I see quite a lot of over-processing in practice, actually, because people are keen to make sure that it's right. And because there aren't that many standards, sometimes one person will do something and a second person will check it. One of the examples actually real in our practice, and 5 years later, I still haven't managed to change it. We have a person look over the day book at the end of the day for charging, because we're not sure that we've charged appropriately for everything. The lean in me is like, why couldn't we get that right the first time? I don't know why. We're still working on it. Overproduction, but buying in too many vaccines. We've had a couple of practices near to us, emails suddenly going, we ordered 2,000, not 200, help. Overproduction can also be having nurses sitting there able to run a clinic that's got nobody in it. It's a mismatch between capacity and demand. Rework, oh my God, redoing repeat prescriptions, redoing the charges, redoing the recall. Let's talk about overprocessing from a recalls point of view. Seeing a patient who's come into a practice, bye-bye, thanks for coming in. 2 minutes later, picking up the phone, hello, you're overdue your smear. And then 3 days later, phoning again, and your child needs immunizing. Actually, I had another practice manager say to me, and I hope you see the funny side of this too, recently who has become a healthcare home. Oh yes, we had to change appointments because one of our GPs was sick, and our staff called the patients and told them that GP was sick. Right. And did they make a new appointment? No. They're going to make those calls next. Okay, good. Right. And I guess, this is about teaching that view of the world. And, sometimes people in general practice, well, we've always worked like this. This is how the recalls work. We print out a list, we make a bunch of phone calls. And the opposite to that, for example, healthcare assistants or PCAs can be really amazing, real holistic, will see a patient opportunistically, open up the dashboard and go, you know what, there's a bunch of other stuff here. Shall we talk about these things? Can I organize for you to see the nurse? Would you like smoking cessation? Wait a minute, I noticed you haven't had a foot check. How about we do all of this right now? And actually that person can sometimes really make a fantastic connection with the patient before they've even got into their journey. We've had lots of patients say, I had such a great, meeting with your PCA, and she set me on, this and that and sorted me out with the other. Fantastic. So the next breakout is again 5 minutes, which I know isn't very long, having a look at the waste picture and coming up with some examples that you know about in your practice of those types of waste. And then when we come back, we'll share a few. That would be great. Hi, so we'll just keep pushing on. Who wants to share with us what they thought good looks like?
We didn't probably talk quite so much about what good looked like, but we looked at waste.
Sorry, waste. Yes,
yeah. So I actually mentioned one that I was asked to share, and I might actually reach out. Forgive me if I don't explain this very eloquently, but diving into some data for consult types for practice, and I thought, oh, these numbers are huge, and happened to notice for one patient that they, for example, had medical screening with a healthcare assistant, and then they went and had their face-to-face. Interestingly, this practice also has an urgent care co-located. So it seems, looking at the data, that every touch point for the patient creates an entry for a consult. So if I'm going to use this for capacity planning with the practice, whilst the percentages probably remain true, the actual volume isn't quite accurate. You know, face-to-face is completely blown out, whereas actually it's going to be 50%, if not 33% of the numbers. So that was just, I think there is waste there, but probably also just the data check, which
really
could be wasteful if you don't check it.
That's right. Thank you, Rebecca. It's a great example. I always think that we need to bring data and process mapping or Gemba walking and discussion together, because sometimes the data doesn't tell the full story, does it? Anyone else with examples of waste? Okay. What I am going to do is just give us a little bit of a chance to ask some questions based on the last few slides. Jess picked up a question by chat. Somebody asked, what telephone system do we use? I thought that was an interesting question. I think it's an interesting question because we use Maxicom, which is neither here nor there. I guess I found myself asking, why does that person want to know that? Or why is what telephone system you use, why does it matter? And I just wanted to talk about that briefly. Of course, it definitely matters if you, the one thing that matters about your telephone system is knowing how many phone calls you're getting. So a system that provides you with some data is pretty critical. If you don't know how many phone calls you've got, how many you're missing, when they're coming in, you're blind. So there are different systems out there. Some are better than others. TMG have a system which has got really fantastic performance data that is probably more advanced than what we have. That's a really important part. I think the other thing I would say about telephone systems in terms of functionality is post-COVID, having a system where, for example, the TMG system, you can route your calls that are using the practice telephone number to mobiles, and the cost is still through the main system, and the patient isn't getting the mobile telephone number. For example, if any of your healthcare practitioners called them using a mobile, that's pretty cool. So having something that's very flexible, that you can drive from within the practice, that gives you numbers, those are the important things. But what I would also say is the software itself is not the magic bullet. You know, that's never the case. There might be cool software out there, but what is it going to do for you? If that's of help. Are there any other questions before we move on to the next bit, which is still about lean, but also we're moving into lean leadership? We covered a huge amount of material around waste, and Rachel.
Mel, I've got a question.
Yes.
In terms of GP clinical triage, and it's a bit linked with the phones, in terms of how many, and this is, and again about rework and waste, about people not picking up phone calls because of caller ID, or how do you get around that? Do you still, does your reception say you might get a call, but it will be caller ID or call blocked? What's your thoughts around that?
Yeah, when we say you will get a call from a clinician inside the next 30 minutes, please stay by your phone. This is an important call. If we're calling from within the practice, the caller ID will be the practice because we're using the telephony system. We won't be using, typically we wouldn't expect a healthcare provider to use their own personal mobile to make a phone call. And kind of it's linked to what I was just saying a few minutes ago. If you found yourself having to deploy everybody back home again, ideally you should have a technology platform that means you can carry on working in the same way. You're not asking people to block their mobile numbers.
But you don't block the practice number?
No, they know it's coming from us. Yeah.
Okay. Because lots of practices have caller ID on, which is people don't pick up. So
yeah, okay. And I guess it's, you know, some of that, one of the things about standards is it's also, one of the words we use is expectation. What's the expectation? You know, in the service and product industry, like for example, franchise businesses know that they set an expectation and they meet it. Doesn't mean your burger's the best burger, it's just the same burger. I know what it's going to taste like when I go to that shop, tastes the same, great, awesome. In relation to the services you provide to your patients, it's the same thing. If they know how you work and you work like that consistently. So maybe if we just come back to clinical triage, I've seen practices who are in the early stages of implementing clinical triage, and they'll call some patients back, but not all of them. Or they'll go, we call patients back when we haven't got any appointments, but when we have got appointments, we just give it to them. Well, that's really confusing. From the patient's point of view, you don't know what you're going to get, no idea. It also, in a way, hinders adoption. So when you first implement clinical triage, patients sometimes might not like it because they're not used to it. It might feel like you're saying, no, I'm not giving you an appointment. So we do quite a lot of coaching around how you handle the call so that it sounds like, yes, a clinician will call you. They may be able to resolve your need on the phone. If you need an appointment, they will give you one. It's yes and yes, not no and no. And then, of course, follow through with consistent delivery. Don't say, I'm going to call you, and then don't call you. Or I'm going to call you on Monday, but not on Wednesday. So, yeah, delivering something consistent with clinical triage. And this is just a little aside, but something we've recently been experiencing. There has been an increase in demand, same-day demand recently. There's quite a lot of respiratory in there, any of those of you who have been looking at that sort of demand in general practice. And we have been really low on capacity in our practices. We're actually 2 GPs down as a result of not being able to bring in GPs into the country. So it's hard work. And we decided to stop offering clinical triage calls after 2. Because if you say, I am going to call you back, this is the way I handle your urgent request, I'm promising to call you, and then you don't, and you get to 5 and there's still 10 calls on that list and they're urgent, right? You're actually opening up clinical risk and setting up unrealistic expectations. So it is more honest and more real to say, I have run out of the capacity to make clinical triage calls and make appointments today. That is the reality of it. I cannot help you. Please go over there. And those are kind of hard decisions to make, but we also need to be honest about, because otherwise we have had cases where there was a patient sitting there who wasn't called until 5, and actually it's a child who urgently needs to be seen. You know, so remaining true to that, the nature of what we do. Any other questions? Is that a hand, Marianne Kluard? A hand? No, that's not. It's not a hand. It's my cursor. Okay, I'm going to go back into sharing then. Hello, Marianne, though. Though I can't see her face. Marianne has been in Tikipunga for many years, isn't anymore. She's at Mahitahi, but walked the walk together with me. Okay, so a couple of more lean tools, and then we'll talk a little bit about lean leadership. So one of the things I talked about was building improvement into the practice, or building it into the practice rhythm. And many of your practices will be using huddles in the morning, but huddles are something you can use everywhere. We, for example, have a weekly admin huddle, and literally the team bring their chairs in a little circle. We spend 30 minutes going through a standardized agenda, clinical triage, customer incidents, how's reception feeling, any problems, rosters sometimes, so basics. And it's a great place to identify and improve something quickly. So the thing about having a meeting weekly is that it's not that long between the meetings. You know, a problem doesn't sit around for 5 weeks before you do something about it. And certain problems in general practice, for example, if repeat prescriptions go wrong, say they're not going to the pharmacy electronically, it's a high volume item with high customer demand behind it. Things go pear-shaped really quickly. You know, within an hour, you've got patients calling, going, where the hell, I'm sitting at the pharmacy, what's going on? And within another 2 hours, you've got 50 backed up prescriptions. So the point I'm trying to make is related to the volume of the thing. Some things you need to meet and change really quickly if they're going wrong. Clinical triage is another one of those. If you're starting on the clinical triage journey, meet really robustly, weekly at least. Look at the data, talk to people, how's that going, what's going wrong, and then you know, make your tweaks. Having a monthly meeting for all your staff and building in improvement and your visual board. I don't know how many of your practices are using visual boards, but having that concept of, if I work in this practice, or for example, as a PHO facilitator, if I go into this practice, am I able to walk with whoever's receiving me or hosting me and say, what's your purpose today? What's your purpose this month? Where are you going this year? How do I know it? How far have you got? Who's involved? How do those staff know they're involved? How do you drive that forward? Those are great lean questions. And as a PHO facilitator, I would also be asking myself, and how can I add value to help make this happen? So one of the things that I was coached by Dani on when I was a facilitator is deliver value when you're in practice. Don't just go there, say, you've not done this and leave, or be nice, because that's not value. Actually deliver value. So think about, what is it that I'm going to do when I go in practice? And it may be Gemba walking and lean leadership, which kind of cues the next bit. I just wanted to share this beautiful example of visual management from Te Hiku Hauora up in Kaitaia. This is 5 years old now. It's a Monopoly board, and those of you who are still wide awake, you can see all the components of care. In fact, this is an old Monopoly board. The components may have got a little bit updated. And Te Hiku was using houses and hotels and little construction things in their main staff room to talk about which bit they were working on. And they also had a performance board opposite saying where had they got to on that. So that's just a very great example of making it your own. And there are lots of practices out there. You know, there's a standardized lean board, and that doesn't stop you coming up with your own fantastic ideas, which inevitably is exactly what people do. Jess was quite keen on me to cover patient journey mapping or value stream mapping, and I said no. Because value stream mapping is a workshop in its own right. But I think it's worth just saying, whilst we're covering the lean tools, I will be talking about structured problem solving in a bit. When it comes to, okay, we found a problem, how do we fix it? Lean teaches us to think carefully before we just knee-jerk react, and understand the problem and understand it from an end-to-end point of view. I've already started to talk about, if I, the receptionist, see this part of it, I don't know what happened before and I don't know what happened after. So it's quite helpful to come together and map it out. And there are tools appropriate to the size of the problem. So if it's a little thing, or, you know, not too complicated, you can probably use structured problem solving, and I will talk about that shortly. If it is a big, complicated process or journey and has multiple providers, possibly organizations, so yourselves, an NGO, 2 practices, the District Health Board, Alzheimer's Association, value stream mapping, or actually mapping it in work streams with post-it notes, is a really valuable way to see the full picture. This particular example was the orange in the middle is the patient, and the patient was there, they were in the room, and that was their health conditions. So you can see how complex that is. And that started for them as a child, not just health-wise, but social-wise as well. They were homeless for a period of time. It was a very sad story, actually. I remember feeling incredibly humbled talking to this person. And the different colors around are the different service modalities. So there's district nursing, there's primary care, there's community services, there's some social work in there. And we used the colors to map all those different interventions over a period of time around the patient. So we were kind of taking value stream mapping to a slightly different place, thinking about it as integrated care or integrated models of care. That, as I say, is a subject in its own right, but I just wanted to give you an example of visual management and mapping, and also talk about the business of seeing. And in a workshop, when you have multiple providers say, okay, I said that this happened, and then this happened, and then this happened. So there's a narrative component. We hear each other and we get to see the full picture. I haven't touched on change management much in this particular presentation. But anybody who knows the ProSci model will know that awareness and desire comes before knowledge and ability. And using mapping can help drive awareness. So sometimes you might have people who don't think things should change. They think they're just fine as they are. And maybe from their point of view, they are. But when you see the whole picture or you listen to others, you might see it differently. So mapping a patient journey, listening to the full story, standing together and saying it as a narrative, even putting post-it notes on the board, is a fantastic way to generate awareness and desire, you know, hopefully for something different. It's also quite powerful to listen to each other as a team. Like if a manager comes in or a PHO person or a change manager goes, well, I think it could be different. Well, you know, what do they know? So the people who work in the business trust the people who work in the business, ideally, and listen to each other, you know, and that through that way put on their lean glasses. And certainly as PHO people, when you walk into a practice, say to yourself when you go in next, have I got my lean glasses on? What does that mean? Maybe remember the waist picture. Oh yeah, I remember that. And what I also say is, where's the visual management in this practice? So for example, have you got a COVID amber corridor and a green corridor? Have you got a section where people can't go unless they're in PPE? Is there a sign there? Do we know? We sometimes use visual management if we forget something. So if we're changing something simple, could be double booking of a treatment room. We had that problem recently. And we want people to do something new. We wanted them to use a single template. So our rule was, if you haven't put it in the template, you can't use the room. People would show up, oh, you're using it, but I've got a patient. So then we created a template that was on the door, just for a short while. That's not how we work, but for people to remember, to be able to go, no, you haven't booked it. Oh, okay, I'll book it next time. So using visual management to support change. Okay, how are we? We've got 35 more minutes. So the last several slides, there's still plenty to go, are about leadership and change. And lean leadership supports the use of the lean tools and teaches lean by how we talk and listen to people. And it also drives improvement culture. So, you know, start moving into the culture component of what we're talking about. And I wanted to start with some fundamental shifts from I know everything, I can just tell you what to do, to neither of us know how this works, but together we can work it out. From, okay, I can fix it immediately, to actually looking at root causes. And well, as I said, we'll talk about root cause analysis and structured problem solving shortly. From setting general goals to being connected to helping people set their own goals. And some of this, there's more reading on this. I don't think I've got this in this particular slide set, but if you want to Google wicked problems and clumsy solutions, or you might already know that stuff, when we're in a complex industry, and the health service delivery is the most complex service delivery industry in the world, sometimes our problems are linked to multiple sources. Some of them we might not even be able to change. And so what we need to understand is that we might not just be able to fix it based on previous experience. We may need to collectively with our teams go to a new place, do something we've never done before to try and make this better. And also know that it could be clumsy. It's not going to be perfect, not the first time anyway. And sometimes health people really struggle with that. They want it to be perfect. They're like, it's not right yet. And this is a little bit of a change management thing as well. Sometimes if I'm working in general practice and we want to try something new, good clinicians often who are precise scientists will say, but this could go wrong and this could go wrong, and what about this and what about that, and hang on, what are you going to do about this, and have you thought about that? And those are all good questions. But what we will do is start small, one patient, one time. Okay, yeah, all right. Shall we see how that goes? Yeah, okay. Clinical triage is a good example. Virtual consults is another one, you know. and then learning and building, by the way, together with the patient or together with the consumer, you know, not just us, but actually, how was that for you? Again, it's blindingly obvious, but, you know, don't sit in the boardroom dreaming it up. And looking for immediate fixes is part of that primary care reactive culture, but also Joe Henson always says, deep and thoughtful preparation, quick execution. I will actually, now that I saw Marianne Clouard in the audience, Marianne implemented a model of care developed a bit by the King's Fund a few years ago called micro teams, which is just really bringing GPs and nurses and PCAs together in small groups around small populations of patients. And she did a lot of planning. She looked at her capacity, she looked at her processes, she looked at her skill sets, she understood it. She ran a pilot for a month with one nurse and one GP. And then on a certain day went, okay, the whole practice is going to work like this. And it was smooth as. She was just peachy. It was like, that's fantastic. And I later thought, you know, how did we do that so easily? Well, it was deep and thoughtful preparation. That's why, that's how. And bringing people with you. Not, you know, bang, okay, today we're doing this differently because everybody's super confused. And connecting the organization goals to individuals' work. In other words, there's a whole piece around visioning and future goal setting and strategy, and everybody understanding what their part in that is. Not strategy being a special book that the board do, and down here on the ground, we just carry on doing what we always did. And so this is also shifting away from one special person who knows everything and can fix everything. What I sometimes call seagull management, where somebody flies in from the top, leaves a poo, leaves. It's not that. It's where the person who is the leader or the leaders and the managers, or, you know, people who have broader responsibilities for teams underneath them, share everything. They share their knowledge. They disseminate standards. They don't hold on to special things. They share the ability to problem solve. They're not the only problem solver. And what it also makes me think of is, if you think back to lean and waste, being a bottleneck is a waste. Sometimes there's only one person who knows the locum login, or only one person who can sign off timesheets, or, you know, do special COVID claims. Well, guess what? That one person becomes the bottleneck, don't they? And then that person's like, I can't keep up. So it's a bit of a kind of dichotomy in a way, because sometimes in general practice, the leaders have been there for a very, very, very long time, have grown over years and years and years into a certain position, particularly non-clinical leaders. They do know everything. And it's quite hard work writing that all down and explaining it all to people. Why don't you just do it? And there's almost a sort of be superwoman culture. And I'm always like, don't be superwoman. You're fantastic. Just being you, that's fine. Don't be superwoman. And share rather than hang on to. So instead of doing it for people, what we do is we empower quality through standardization and through performance and improvement, and through leadership talking and walking, through setting visions and then helping people work through how they get there. And quite a lot of that is very active. It takes effort. It takes effort to say, who am I working with today? Why am I doing that? What's my message to them? How am I going to help them before you go in there, rather than reactively, I can solve all your problems. And really what we're starting to move into is change and leadership for change. So setting aspirations, showing the way, you know, there is a way out of here. This can be a lot better. I know it's really hard at the moment. Something that I learned quite recently was somebody said to me, when the troops are in the trenches, you know where they want their leaders to be? In the trenches with them. That's where. Not in, you know, in some house somewhere. And so we've had lots of workforce challenges. We got down to way less GPs and nurses than we should have. That's really, really hard for those people. And my role for sure was right there with them, not doing the doing, because by the way, I'm not a doctor or a nurse, so that's not going to work. But sitting together, for example, weekly and going, okay, what's our strategy? What can we deprioritize? How are we going to catch up when we get into catch-up mode? Who's doing what? How can we solve this? Where are the holes? Very soon, the team were answering those questions. Okay, I'll do extra time on Tuesday. Hang on a minute. What about if we get a remote nurse who can work from Auckland? Right. What about if we do? Fantastic. So that's, I'm back to like, don't waste a good crisis, because actually sometimes people really show their colors and they're amazing. They're awesome. They're coming up with these incredible ideas. They're working like a team and agreeing a plan. You know, I'm an ex-project manager. I will always say, what's the plan? Let's at least have a plan. And then when we meet next week, there might be bits of that plan that weren't right. That's okay. It's working with people, setting a time and a place to plan according to what's going on. They may be very short term and medium term and long term, depending on what kind of a crisis you're facing, seeing it that way and working through improvement, and having some kind of visual board and or data that supports all of that korero. Yeah, that's it. And it takes years. The PHOs, that'll be you guys, all think it goes quicker. It takes a long time. And in general practice, you can actually get to a certain place and then a proportion of your staff leave or your GPs leave, and then you're back at it again, aren't you? You know, retraining, resetting the standards, re-going. That's not how we work here. I've had people come into our practice from other modalities. Oh, I'll just knock on the GP's door and kind of ask them, well, actually, we don't work like that here. And why not? Because we don't believe in just interrupting people. That's why not. There's more to it, you know. So it takes time. I think it needs to be deliberate, particularly on a leadership point of view. So there will be days across two practices that I will go into practice and I know I'm not going to get anything on my task list done. And instead of feeling frustrated by that, thinking, oh, I've got all these things to do, I was like, today is the day when I'm going to listen to the people that I see. I'm going to Gemba walk. I'm going to enjoy the interaction with them. I'm going to sit in the staff room and hear what people have to say. And yeah, it could be hard. All of it could be hard, but that's what they're going through. So, you know, yep, I'm going to listen. And then I'm going to somehow put it somewhere and somehow kind of get some order on it so that we can do what we can do, but not drive ourselves to a place where we are actually setting ourselves up to fail, because there's that as well. How are we doing? Yes, on time. This is from a lean manufacturing book, actually. And it looks really complicated, doesn't it? It talks about lean leadership habits, operating processes, that'll be standards, root cause analysis, I'm going to talk about in a minute, performance expectations, set clear expectations, map those. I've talked about leadership. Supporting for people, I've also talked about, and I'd like to talk about a sense of purpose. I sometimes use the words a sense of urgency. There is a happy optimum pace. Asleep, that's not a sense of urgency. Burning ourselves out, okay, that's too much. Somewhere in the middle, you know, hopefully the pace of this workshop means we're getting things done, but we're not over pushing ourselves. And I've just pulled up some bubbles there to link this kind of quite theoretical lean stuff to what we've been talking about today and to things that are very practical in general practice. Standardization being a really important part, because how do you know where the waste is if you're not following standards? And once you know what the standards are, you can start identifying the waste, and then you can start doing some problem solving, which we're still going to talk about. And then you're going to put it on a board, or you might chart it on a computer somewhere. Clearly, your leadership needs to be aligned, not saying one thing and doing another, setting tangible goals and treating each other with respect. And one of the things I also wanted to talk about was when we are in this territory that we've never been in before, and COVID put us in that territory, but we're into that territory now and into the new shape of healthcare. We need to be a leader who says everything is going to be fine. not, oh God, okay, what are we going to do? Anybody who follows the America's Cup will remember there were lots of accidents in the early days. And every time they happened, what the team said was, that was a great learning opportunity. Oh, yeah, no, brilliant learning opportunity. So seeing it that way and knowing that you're going to fall over, actually what happened, anybody who's a very keen sailor, when they first designed a foiling hull, what the America's Cup team said was, let's make this so futuristic and so high performing that it's actually really difficult to sail, and it's going to take us a year to learn. We're just going to fall off, right? That's how it's going to happen. But when we show up, the Americans will have 7 days. They might be able to do the tech, but they will not have the time to do the learning. And that's exactly what happened. So setting a team aspiration to achieve something very amazing. And we're starting to talk about transformation rather than just like tweaking in processes, and knowing that it's going to be tough and you're going to make mistakes. I would come back to, and I hate the word telehealth actually, video consultations or using the modality of video to provide healthcare is an untapped, area, an area that we're not in yet. And it's an area where we are making lots of mistakes at the moment. And that actually is where the juice lies. What are those mistakes? Tell me about that. What is it? Because that's exactly where the improvement lies. So instead of saying in one of my GPs, well, that was rubbish. Okay, why was it rubbish? Well, I mean, I couldn't even find the bloody phone. And then I didn't know if the patient was there or not. And then, I was running late. And then, okay, that's all good information. How can we have a waiting room? How can we help the patient know whether you're, if you're running late, how do we let them know? Blah, blah, blah. So I hope that I have covered reasonably effectively the lean tools and how lean as part of Healthcare Home is not doing lean. It's not doing a 5S, although that's an important thing. It's the tools help you be a better practice. The tools help you implement clinical triage, do the call handling, have capacity to meet demand, blah, blah, blah. The worst way to look at the Healthcare Home is as a tick box exercise. Have I got this yet? Tick. Have I got that? Tick. Oh, okay, I'm a Healthcare Home now. Because we've already seen it in the journey. Healthcare Home, of course, changes because the world is changing. So if we do exactly what it said 6 years ago, that's not right. It's about embedding that understanding and thinking in your practice and helping everybody to see, firstly, why should we even work differently? Can I be bothered? What's my part in that? Do I get to say, one of my admin team who's been in general practice for 20 years, she said to me, oh yeah, there's always a new manager. They show up and they go, we'll change all of that. And the admin team think, oh God, that's what the last manager did. And then they change it and they leave a year later and the new manager comes and goes, oh yeah, we're going to change all of that. And they put it back to where it came from. So it's not change for change's sake either. And something that, on that subject, sometimes, particularly when it comes to software, we will see something somewhere else. Let's say another PHO has got some fantastic piece of software or another DHB has got something. And we'll come back and we'll go, oh, I saw this amazing thing. All right. It was really amazing. Oh, good. Yeah, it was fantastic for them. Let's get it. And I will, what for? Because their problem is different to our problem. I'm moving into structured problem solving, aren't I? I'm going to come to it then. So we're talking structured problem solving. And what structured problem solving is about is it's linked to the deep and thoughtful planning, quick execution concept. That when you have, okay, repeat prescriptions, we keep getting errors. There's a really high error rate. We've done some analysis, 20% of them have to be reworked. That's worth spending some time on. Right then, how do we do that? And this is something we teach everybody. And when we prioritize the problems that came up in the week and we start actually choosing to work on some of them, we would use this method. And what we would firstly say is be specific. Define the problem well. So the problem might be, we have regular rework, I don't know why. That might be the problem statement. That's all we know. Defining the problem well is important, particularly in a reactive nature. Sometimes people will come with like a little burble of many problems. I was late today, and then the fridge wasn't working, and then after that, the patient didn't have somewhere to park, and then, you know, the call system's rubbish. Okay. Did all those 5 things equally important? Yes. Okay, we'll name 5 problems. Let's unpick it for starters. It also helps overburden. Sometimes people just feel really overwhelmed by all these problems. And just by going, okay, whoa, like one by one, okay, there's 5 problems here alongside another 10. Which 3 shall we choose? And we'll do some prioritization there. Okay, this one. Now let's be specific about the problem. So firstly, define it well. Secondly, you might say, okay, now we understand what it is we're trying to fix. How often does it happen? So put some data to it. Another really practical example, we had one GP who's routinely, Marianne knows exactly who it is, running late. They're just that kind of GP. And we thought perhaps this is happening too often. So we said, you know, you're running late and we know why, but like, can we help? You know, can we maybe lengthen your appointments or something? And the GP's like, no, I'm not. Honestly, I'm not. And my patients don't mind. So we said, well, can we go and prove that? You know, Lean will say, go and prove it. If you don't know, if you're like, I think, but I'm not sure, well, go and measure it. Okay. A week's worth of measurement of how late are we running exactly. And if my patients don't mind, well, let's ask them. Okay, you're routinely running late by 20 minutes. Every Thursday afternoon, you're running an hour late. Here's how your patients feel about it. Some of them, oh, really good doctor. I don't mind. Oh, I know that about him. And then, okay, what are we going to do about it? Because also we don't have magic wands. I recognize that. Sometimes we can't just go, you know, these appointments should be 30 minutes. That's what they should be. And I'd love to do that, but it's not going to work financially. So what else can we do? So firstly, define the problem well, then do root cause analysis. And this is straight up why? As a PHO facilitator or as a manager, you can sound really boring and almost pedantic. Why are we having 20% errors on prescriptions? Because e-prescribing's fault. Well, why is it e-prescribing's fault? Because we're not setting it up right. Well, why aren't we setting it up right? Because only one person knows how to set it up. Okay, and why does... All right, so if we all knew how to set it up, we wouldn't have so many problems. Cool, bananas. Let's go and try that. So come up with some solutions. Verify. You're into the plan, do, study, act cycle. You all know what that is, don't you? Did that work? Oh yeah, but there's still something else. Okay, what is it? Well, the error rate has gone down, but the controlled drugs are still a problem. Okay, why is that? Well, because we don't know which pharmacy they're going to. Why don't you? Right? You're with me. I'm going to give you another example of using structured problem solving in practice, because you can come up with a million process examples. But I worked with a practice many years ago who decided something was really important to them, that they wanted to do structured problem solving on this. And what was important to them was that their manager at the time said they had too many nurses. And so the nurses were like, this person doesn't value what we do and they don't know what we do. So we said, well, let's use structured problem solving. Let's define the problem. What's your statement? And the statement was, we don't know what value there is in nursing. We don't know, right? That was the statement. Okay, cool. Why don't we know? Wow, massive subject, because we don't record it, because we don't see it value in financial terms, because it's unseen, because nurses run around in corridors and nobody values that. Why else? Because we don't want to charge for nursing. Oh, why is that? Right? There's a pile of really valuable questions there. So structured problem solving is not necessarily only about a process step. It could be about an attitude. It could be about a culture. It could be about a perception. I think what's helpful about it is it's helpful to coach people to talk about problems in a structured way, because it helps remove some of the kind of emotion that's attached to it. And it's okay to say, I'm very upset, but if you stay in very upset, you're probably going to find it hard to work out what to do about it. So it's kind of a moderating tool as well. Time. How are we doing? I've got 3 more slides. Change curve. Hopefully many of you have seen this before. Those of you who haven't, you'll know, anybody who's a clinician will know the Kubler-Ross grief curve, which is where this came from. I find this incredibly helpful to remember, particularly when you're trying something and things start going horribly wrong. You can try something new. You can try something you've not done before, video consults, and the patients miss them and the tech doesn't work and the thing falls over, and you keep trying and nobody likes it, and patients are going, I want an in-person appointment. And that, as a leader, it's important to know that you are going down the trough of depression. That what happens when you go through change is that at the beginning, it's what they call naive optimism. Before you do video consults, you're like, they're going to be amazing. It's going to be so easy. The technology is awesome. Let's do that. Then as you start doing it and it goes wrong and people are tired and there's a lot of other pressures, you too. Oh, God, can we just not go back to the old days? I can't do this anymore. And that's a good time to remember. And I sometimes remind myself, oh yeah, we're in the trough of depression. And it's a good time to say to the team, you know what, this is going to get better. I know this is hard. I know it's awesome that you're still committed. Actually working as a team, showing up for each other. You know, it's a bit like going to do sport, showing up on Tuesday, because that's the meeting about video consultations. Even though I hate them, I am still here. Do them, keep the rhythm, keep trying, and then slowly start developing little islands of success. Oh, that worked well. Gosh, that was a good, oh, wow. And share it, you know, tell the stories. We had a really good consult on Tuesday. What was that about? Why don't you share that with everybody else? Well, blah, blah, blah. So that eventually those islands of success become, you know, bigger and bigger until you're in the point where adoption, in other words, we are now working in the new way and we've forgotten all about the old way. And I say that in a kind of, because sometimes before it happens, we are hanging on to the old way, but this is going to go wrong and that's going to go wrong. And then when we're in the new way, oh, I've forgotten all about that. Don't know what that was about. This is cool. We're here. And then you're into the next round, of course. So bearing in mind that, you know, point, and also not catastrophizing together with everybody else, by the way, even if you feel like it. When everybody else is going, you kind of have to stay cheerful. It's going to be okay. Great learning opportunity. Tea, cake, etc. And what I'd like to finish on also is you can do new stuff and you can start small and you can get better and you can have everybody working at it. And then for goodness sake, actually go for adoption. Don't just do 6 new patients on an MDT and go, we did MDTs this year. So there are lots of small pilots that never go anywhere. Actually sustaining, making it the new standard, and checking for slip back, because slip back is actually really quite significant. As soon as you leave it, guess what? One of the things I found really interesting about clinical triage is we had clinical triage locked. You know, I was, yeah, we've done that. That's how we work. And then we had some extra demand, really increased, and people started giving appointments away. I'm like, wow, what? We didn't have time for clinical triage anymore. No. Clinical triage is your tool. So, you know, watching for slip back and then bringing people back again. And so, you know, staying committed, staying consistent, and then spreading across the entire organization. So also going beyond special people or special champions to everyone as much as possible, so that it is common knowledge. And for those of you who know the PDSA cycle, really what you're doing is starting small, 1 person, 1 time, 2 people, 2 times, the chaos of the early days where you're doing lots of refining is kept to a small group because it can be exhausting. And then as you start developing a standard, broadening that to, if I come back to the clinical triage example, to a time where everything is being managed in the same way, not with clinically triaging for some patients on some days with some GPs, but for everybody consistently in this way. And that is the end of my slides. So I'm going to stop sharing just to give people a chance before we finish. We've got 5 more minutes. If anybody wants to ask me and or Kirsten and Jess any questions. You're all...
It was awesome, Mel. Really good.
Thank you. Thank you. Or any suggestions, like if we, I'm sure Jess will be no doubt doing some follow-up. Yeah.
Absolutely. Mel, I had a question. Wendy, I work in Wellington at the Tuora Campus Health, but my question is really around when I work with some practices, some of the things that I have noted, you talked a little bit around culture and around how important or how that influences what change can actually happen. Mm. And I wondered if you had any top tips around, because for me, I guess my greatest struggle is the mindset of this is where we are, this is how it goes. And like you say, some practices have made really great progress, but when the pressure has come on, it's fallen back to this. And so how do we shift that? Or do we just keep going with that? But part of it too has become almost the culture of this team. You know, we're a really good practice, really good, but actually when the pressure comes on, not so much, hey? And that's, I do find it quite frustrating. And a lot of it is that I hear all that stuff. It resonates really well around, we don't have time. You have no idea how busy we are. I've spent a great deal of my 25 years in primary health before coming into the PHO. So any top tips you could have for helping shift mindsets would be really helpful.
Yeah, and what a great question. It's a massive subject. We could have a session on it alone. I think a lot of what I've been talking about today, which is a leadership attitude, role models a lean culture. And the lean culture is firstly respect, and secondly problem solving or improvement, right? And sometimes I make a difference between an old English word is like whining versus defining a problem. And sometimes we need to get the whining done with, like one session. And I mean, I'm there. I know it's hard. I'm not putting people down. They do an amazing job.
That's right.
But kind of once we've got that off our chests, saying, okay, I've, expressed the emotion. Now let's look at it in a slightly more scientific way is a good word, actually. Let's try and divorce ourselves just for scientific purposes. Look at some of this stuff. The minute you step into that, you're stepping into an engaged space as opposed to a chucking stones on the glass house kind of space. There's also a culture of workers expect managers to fix it. Well, we've talked to that, right? It's everybody's responsibility.
That's right.
As a manager, it's my responsibility to enable you, to give you the time, to give you the tools, to give you the space, to give you the coaching. But I definitely can't fix it all. Sorry, I'm not that good. It does remind me though, because it's a good little reminder, and I don't think I said this at the beginning. If you want to Google Joe Henson, who also does lean training, Joe Henson and I do a podcast called Change Jam, and you can just Google Change Jam. And our last subject was on strategy and culture, actually. So it's not affiliated to the healthcare home. It is just Mel and Joe having a korero, and we go off-piste all the time. But we have got lots of lean experience and tools to share, and we were keen to just share them. So you can just Google it, and maybe we can do a session on it another time.
Okay, thank you.
I think I just thought I'd add to that too, Wendy, is that I think you know, there's the big projects like triage and things like that that, you know, really benefit from a more structured approach. But I think day to day in practice, there's always something that trips us up or that needs working on, or a process has fallen over. And I think, you know, always having those lean lens or lean goggles that Mel was talking about all the time, so that we, you know, can actually come from it from a different perspective instead of the, you know, straight, you know, again, it's that kind of get it out of the way of what's gone wrong, but actually, you know, move into quite quickly into a more structured, get your team around you into a more structured problem solving space.
Yeah, and for me, Jess, it's around getting that whole order wellness plan kind of thing happening. Just proactive care with the demands of COVID has really fallen away in some of our practices. And so I'm at the stage of trying to understand what is the nature of the problem, actually, because I think the problem is different for each practice. And so trying to get my head around how we support practices that have actually different problems, but the same, if you will, you know, proactive planning, but they have different problems associated with that. And certainly the data supports that as well. So, yeah.
Has the group got any thoughts, particularly around, you know, I know proactive planning probably is that last kind of thing that, well, the most thing that gets slipped off when practices get busy. Has any other lead kind of had to help practices get back on track in that space? Any sharing in there?
Help me.
Just whilst, because if people are feeling a bit tired, I did have a bit of a thing to say, because you've absolutely nailed it, Wendy, that structured problem solving. So if you sit down with the team and do, okay, why and why and why, it is their narrative in their practice with their patients. How to fix it is not like the practice did next door, right?
No, that's right.
And also when they start saying those words to each other, they move from, I'm ridiculously busy, can't you see how much pressure I'm on, there's nothing I can do about this, to, oh, okay, I'm beginning to understand why. The minute you see why, well, you now know what you can do about it. Oh, why? Because I haven't got any time. That may be real. Why don't you have any time? Because I'm just overbooked with routine appointments all day. Why are you overbooked? Because there's not a, okay, why is that? That's all real. Sure, let's talk about it.
Okay, watch this space.
Probably be very interested to hear any learnings, Wendy, actually. I think probably it's a common problem.
All right, well, thank you so much, and thank you for, you know, for being available visually, because it's super hard to talk to a sea of names.
And so
sorry.
I was just going to say, we'll share the slides and the recording following as well, so you can watch it over and over again and share with your team. So happy to do that. If there's no other questions, Rebecca, did you want to go? Yeah, go.
I just wanted to say huge thanks, Mel, for today. Donna and I have made many notes, and we are really fortunate that Mel's coming next month to provide some training in our region. So just wanted to share the great uptake that we've got. We've got I think it's about 15 PHO staff for the first day, across clinical, knowledge and insights, network support, the whole team, who are really eager to upskill in this space. And then day 2, we've got between 18 and 20, we've just got a couple to confirm from our general practice teams. We've got quite a few new practices, and also, of course, with staff churn, some of the more long-standing practices who've got new staff, so they're coming along as well. So we're really looking forward to it, and this is a really good taster of that. So excellent, thank you, Mel.
Yeah, ditto. Awesome.
All right, well, go forth, and may the lean force be with you.
Thanks, Jess.
Can you share that last slide and we'll do closing karakia?
Oh, yes, that's right.
Please.
Sorry. Yep.
Thank you.
One moment. There we go.
There we go. Thank you.
Okay, feel free to jump off if you like. Okay, all together. Ki horo
Te
te
marero,
ki
ka
whakapapa
whakapapa
te
te
moana, ki
ka
tere
tere
te
te
taro
karohirohi
E
mua
mua
e te horahi.
te
Ka
Kia ora,
pai.
everyone.
Well, that was better.
Tada!
That one was better.
Yeah. Go well, everyone.
Thanks.